Hello, all. This is a supplementary lecture. I'll explain to you, I'll give you more information when we get to class tomorrow. This is the 29th on a Sunday, so if you listen to it, fine. If not, you'll know when you'll be aware of what's going on when we come back and talk about this. This is a chapter, and it should be loaded, but I'll make sure it is loaded on Blackboard, and I will do that. This is Cowan's chapter 11. This has got two features into it, and I'm doing it in this way because of the interest of time. We only have about a dozen lectures together, and even if I do it with some degree of rapidity, for me to cover respiratory, skin, genitourinary, and wound infections at a minimum, that's about 3 lectures a disease entity. I got to get busy on that, and so it gives me a chance to head start it with the two classes this week, which I plan to do on Monday, and this becomes sort of a self-study chapter because effectively I read the PowerPoint and amplify it, so you can listen to me reading the PowerPoint and amplify it, and rather than I won't get a head start. I will use the 2 days this week to complete antibiotics, antivirals, etc., etc. I am misspeaking again. So let us begin. So you'll see I'm going to just basically it's me reading the PowerPoint and commenting and telling what you don't have to know, as well as you do have to know, etc., etc. And so a lot of this is terminology. This is basically the way. And again, I'll probably do this for half an hour, maybe take a break and do another half an hour, just in the interest of time and saving my voice this Sunday noontime when I'm doing this. This is not a major area, but it's of major importance. It's not something. It has to do with basically what we call our microbiome. All the microbes that are either on us or in us along cavities, even in areas where we didn't think they were, in some what we call sterile spaces like the lung or the bladder, and places where we didn't necessarily expect to normally find microorganisms, even in the central nervous system. And really, that their interaction with us is really what keeps our body in tune. This is the whole idea of when you hear about prebiotics and probiotics, and nutrition, and all of these aspects. They've done so many studies now that we can relatively rapidly, with modern technology, analyze these things about how your relationship to your health. So it's really when it's part of eating healthy, exercising, all the things that we do, and avoiding problems is really how we stay healthy. And so they have effectively colonized us for long term, but don't cause disease. So you're going to see the terms, we'll either call it mutualism or commensalism, and I really don't distinguish it. Basically, they have a place to flourish, and we either benefit or certainly not hurt. It's the distinction between something that an infectious agent, a disease causer like a pathogen or a true parasite. What they do is they occupy us and flourish, and in the meantime hurt us. That's what we do. That's what these guys don't do. This is what our microbiome is about. And they play an important role because they don't cause disease. And really, they're part of our defenses. So the microbes can't get past our defenses and enter tissues and multiply. They can't do that. Okay, when they do that, it can result in an infection or a disease and something that deviates our health. And by definition, an infectious disease is caused by a microbe, some invader, or its products like toxins or enzymes or nasty chemicals, anything like that they could do to hurt you. And you can see the definitions are right there in front of you. And again, they're so generic. Any question like that would be a fairly generic answer. And so this has been underway, for the last 20 years, more or less, understanding how they are, using genomic sequencing, big AI type tools now, supercomputers that have been able. They thought this would take a lifetime. This takes years, and even less. And this gives you an idea. And I've read anywhere between 35 to 50,000. This one says 21,000. Here's a clue. Nobody really knows. I guess I would say at a minimum there's 20,000 of these genes that encode for proteins, and that really makes us who we are. Where on the other hand, with the microbes, there's a whole lot more, and we thought that they are now in areas, as I said before, that are surprising. I mean, in your gut alone, you're putting out 100 million viruses per gram of human feces when you're pooping. A tiny amount, a gram is tiny. Okay, smidge. I mean, 100 million viruses. So we all have bad guys potentially in it. Okay, and so this is understand the fact that they're there. I mean, that's we're eliminating them if you want to think of it that way. You have to understand the notion sterile is only for inanimate objects. Living things are in constant contact with the microbial universe. They're part of us. They help us, and at times they hurt us. So this is really interesting. When I've been to teach this, we call these, when we get to them, where we know they are: skin, linings, start of the upper respiratory, throughout the GI, outer the urethra, external genitalia. All of those are pretty well known. But now in the lungs, who knew? Okay. Typically, the urethra, once it got into the bladder, we thought there wasn't a problem, but now we see it unless it's introduced there. Breast milk, amniotic fluid, and the fetus itself. It's quite amazing. And now we're even things in brain and bloodstream, which is such a foreign idea. But now we understand that it's a much more elaborate. It's not in my area of expertise. That's why it's more of a read the PowerPoint thing. But it gives you some context when you see the vast majority of these microbes are not bad guys. So we have a lot of different things when they talk about environmental niches, or I call them niches: temperature, pH, nutrients, air availability. Okay. And you can look at all these things. The normal ones have they're unlikely to, because they're covering up attachment sites. Okay. We are basically in our environment, we sort of create an environment that's typically hostile to these things. Like I said, there's a lot that we know about this. I don't really care so much about microbial antagonism for your purposes. This we do care about. Why we call these weakened host defenses. It's something you'll hear about: a compromised host. And when you're compromised, you're not at your best. And these are all things that make you more likely to get an infection. So you'll hear the term compromised host. And moreover, when a germ invades that normally would not hurt you, we call it an opportunist, an opportunistic infection. It has the opportunity to infect you when ordinarily it wouldn't. And you see it. And for those of you going into hospital care and hospital based activities, oh my goodness, all you're going to see are compromised hosts, because that's why they're in the hospital. And you have a lot of bugs in there that are only waiting for the opportunity, either on that patient, on the next patient, on your person, on the equipment, to take advantage of their compromised status. They are ripe for invasion. It's our job to protect them. So, you might old age and extreme youth understand that. People with a genetic disease, genetic immunity problems, or a disease that compromises them, if they had a transplant or things like that, fresh post-operative, that's their body's busy trying to help itself. Okay, underlying diseases, cancer, self-explanatory. Liver makes up all your wonderful proteins and all those antibodies and things that protect you. Diabetes, 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 for 1,000 reasons. I know how much you went into diabetes in lecture, but if you didn't go and learn, watch some podcasts, do basic diabetes listening. It's so important. And I'll be happy to talk to you about it, because I didn't teach you that, this particular term. Chemotherapy and immunosuppressive drugs. I told you the impact that these things have. They're so strong. They're designed to damage or destroy certain cells in the hopes that others will flourish. It's really a battleground. Any kind of stress compromises it. Pregnancy, certainly. Another infection that you have makes you more liable to get another. We'll see this again and again. See, even looking in the placenta, seeing this, I don't know enough about this. It's developmental. It's not my area of expertise. But I mean, this is all new stuff. What's interesting is the most important bacteria, maybe the weakest, is lactobacillus. Lactobacillus is you're going to learn a lot about, because it really protects women during the childbearing years from infection, from problems. But here, its name tells you lactobacillus. I mean, it has enzymes that facilitate milk digestion. And you can see different species, different things that it is. Human milk contains about 600 species of bacteria and sugars the baby can't digest. But gut bacteria, and where does that gut bacteria come from? It's immediately during the birth canal passage starts the process. If a baby's born cesarean, the process starts with people who are handling it, the environment that it's in. All of that starts to put together what you and I call healthy gut bacteria, and exactly how they deal with this nutritionally in neonatal care. I am not familiar with, but I mean that's something many of you will learn. But I'm sure they address it. So here, where do they get it? In utero. The womb now has its own. Birth, vaginal and C-section certainly picks them up. Milk, the caregivers, family, anybody who's handling the baby, and the environment itself. As I said, very useful slide. I think you'll be interested in that. And I would be. I'm not worried about answering those questions. I'm not going to ask you about those kinds of questions right now. I really don't think it's part of it. This is very much contextual. And I typically get rid of those things. So I told you before what a pathogen is. It causes a disease, a parasite. The host is a parasite. A parasite invades the host. Parasite, it's got a number of definitions. Parasite is any invasive structure. When you hear the term sort of generically, that's what it means. In the hospital, when they talk about parasitic infections, that's someone who might come in with lice. That'd be a parasitic infection. Malaria, by definition, is a parasitic infection. They're a little bit different. They're talking about eukaryotic pathogens. And so you could see that being, lice are, microscopic insects and sometimes macroscopic insects. They're nasty to have for people to have them, critters kind of things, crabs. So you hear about a lot of these things. And a lot of times they're almost exclusively related to hygiene. And I understand, and I say this to you in all truth, do not be judgmental. When you get there, oh, yuck, why didn't they get a bed? I mean, we are going to deal with homeless individuals and street individuals and impoverished individuals. Understand, I don't, however, here's my saying, by the grace of God, go I, or go you and I. We have the luxury of, place to bathe, live, sleep, warm, at least some creature comforts. Sorry to be preachy about it, but it's important. So the degree that it can hurt you is something we call pathogenicity. And we're going to look, we have ones that always will hurt you if given the chance. So even in healthy individuals, that's when something like Staphylococcus aureus is a pathogen. It's going to hurt you. If there's an opening in the skin or a place it can attach or enter, it is going to cause an infection. Opportunistics are the ones that only do so when your defenses are compromised. Okay. And it's in a part of the body that they are not usually going to. So opportunistic pathogen may be something on your skin that has the opportunity to enter from a cut or a scrape, but your defenses are unable to cope with it. And now it can establish a beachhead. And it even happens in surgery, even in a surgical area. The most common problem with orthopedic joint implants, and we'll learn about this in wounds, because taking surgery as an intentional wound, is called Staphylococcus epidermidis, which we have on our skin, 100% of our skin, 100% of the time. So understand that. All of really maybe the take-home point of this first half is to understand what are called virulence factors. They're not all the same. Every bug, every bacteria, every virus has different ways that can hurt you. Some can hurt you with one tiny exposure. Some you have to have a profound amount of contacts with. And you'll hear me say it again. You probably have. It's a numbers game. So we measure the degree of pathogenicity as a matter of its virulence, nastiness index, how much it hurts you, how much damage it causes you, how easily it does it, how rapidly it does it, how difficult it is to treat. Those are all virulence factors. So, any characteristic or structure of the microbe that contributes to its ability to establish itself in the host and cause damage. How hard it is to find. What kind of little nuances does it do inside of you? All of those type of things. I talked about tuberculosis. It hides in plain sight. It lodges itself inside a white blood cell, and it doesn't start to change that giant macrophage until it really starts to get going. And by that time, you're in trouble. There are a lot of clever ways to do this. I do not believe that the majority of infections are polymicrobial, meaning more than one. I think there's usually one bad guy. It may be enabled by others who have paved the way. If you want to define that as polymicrobial, then you can make this case. I think that's painting with a very broad brush. I look for the culprit. It's when I have diabetics, then I start looking for polymicrobial infections. When I look at compromised hosts, then I start looking for polymicrobial infections. When I look at a class like any of ours and I see young, healthy individuals, I look for one culprit. Okay. Now, this is not influenza leading to pneumonia, is not a polymicrobial infection. This is the initial infection. Oops. The influenza, and the secondary infection, we call it secondary pneumonia. And indeed, the leading cause of death is not influenza when you get the flu, it is secondary bacterial pneumonia. Primary, secondary, not polymicrobial. It always bears repeating. Whoever makes these PowerPoints up is not a scientist, is not an epidemiologist, is not someone necessarily with expertise in this. They're hired by the publisher to make up the PowerPoint. I'll buy this. 95% of all skin infections we see are Staphylococcus or Streptococcus. And Moraxella, you don't have to know what it is. It's a bacteria. It's part of our normal flora. We typically find it inside our mouth and throat. It's always there. And yeah, if you put them together, they could cause problems. I'll buy that. Does that make everything polymicrobial? Hardly. So we will classify this page as BS. Important parts of it: portal of entry and portal of exit. Portal of entry and portal of exit are often similar in the sense when I have the flu, I inhale it. When I cough and sneeze, but it's because of it, I spread it. That's portal of entry and portal of exit. Normally, they are the same. When I have gastrointestinal disease, fecal to oral, typically it's entering through my alimentary canal and is exiting through my alimentary canal. Some skin conditions are very often passed skin to skin by contact. So it's on the surface and direct contact to some other surface. Okay. That's They're not always the case like that. It's just not always the case. It's rare, I would say, than common, rarer than common. But I mean, I think that's a pretty consistent relationship with the way I would define it. Very good. I'm just checking a message. Exogenous, typically staph and strep. Most of the time they're outside of our body. Endogenous, somewhere inside the same human host. Yeah, not a big deal. So, and will I buy that they go to a specific portal of entry? And I mean, this is what I told you before. If they're in the wrong area, I mean, pardon me, if you get a cold virus on your skin, it's not going to enter your skin. Okay, it's not going to cause problems. Even if you have a little cut or a scrape, not going to cause any problem. That's there. But if you don't wash your hands or do whatever kind of hand care or put on gloves, and you touch your face like we do 5,000 to 8,000 times a day, you can easily inhale it. Okay. So this is what they're telling. Same thing I'm saying. Some things can get through different ways. Even though tuberculosis is almost always respiratory, conceivably it could get into the gastrointestinal tract. I mean, here, staph and strep, there's other areas where they can get to. And it all depends. And again, I don't know if you say it 1,000 times, hand washing, hand washing, hand washing, hand washing. And so you can take a look how they enter, whether it's irritation of membranes, whether it's a bug bite, whether it's through the conjunctiva, whether it's GI, you can figure out how that gets there. Important term, fomite. If you're eating or drinking, a fomite is an inanimate object that has the organism. Is it a dirty glass? Is it a dirty spoon? Okay. Technically speaking, if the organism is in a beverage that you're drinking, effectively that's a fomite, whatever it is, the the cup of coffee that may have the infection in it technically is the fomite. Any inanimate object, it's not specific. Okay. It's a different. We're going to talk about direct versus indirect. When you get something directly, the person next to you in your room, your roommate, your person next to you in lab, the person next to you in lecture, all of a sudden has a coughing and sneezing fit, and you're next to them, that's getting to you directly. There's no inanimate object. Indirectly, they cough or sneeze. It gets on the table. They don't wipe it up. They don't have like little, some kind, maybe little hand sanitizers, maybe little Lysol or Clorox wipes, which are easy to get and keep in your backpack or your purse or whatever, your pocket. Wipe that baby off, dry it off, and you get it on your hand, touch your face again. Hello, that is indirect. There was an inanimate object in between. That makes it indirect. Again, whether it's liquid, solid, whether somebody's sick at a food service place and they contaminate the food, it's on the food. The food is an inanimate object. And you eat the food, that's an in between. Yeah, I know they're the ones at fault, but not directly. It is indirect because an inanimate object was in the way. Generically, we refer to those as fomites, Fomites, as you can see here. Obviously, that's a test question. It's important. So I don't need to read this to you, but we were going to cover a lot of these in diseases. You can see inhalation is pretty straightforward, eating, drinking, skin to skin, those types of things, urogenital. And I mean, we'll get into all of this when we talk the specific systems that are there. It's really important. It's called the ID or infectious dose. Things that are nasty have a very low infectious dose. For instance, the minimum number to cause an infection to proceed, the smaller the dose, the nastier it is. Q fever, which I don't even know what that is, off the top of my head. It's very little of it around. One. TB, giardiasis, coccidiomycosis, which is valley fever. Giardiasis, my kids got from contaminated water. 10 cells. TB, one of the problems with TB, even though it's a small dose, you need your immune system can deal with it, but it needs continuous exposure to take hold. So it's a little misconcerted. Gonorrhea, extraordinarily, that's a small dose. When cholera, one of the dreaded diseases, terrible, typically was the greatest killer after natural disasters in war-torn area because of the water supply was fouled with this horrible thing. 1 million, I beg your pardon, 1 billion cells. Salmonella is about 1 million. Okay. When you have a very high infectious dose, and we'll see it depends. Salmonellosis is about 1 million cells. You'd have to have a chicken sandwich, just chock full of salmonella, as opposed to something called Shigella, which is a bacterial dysentery. Again, it's only maybe 100 because salmonella is relatively easily killed by stomach acid. Shigella is not. Okay, these are all the things. So look for infectious dose, low ID or infectious dose, higher degree of virulence. How easy it attaches, higher degree. It attaches easily, gains a foothold, starts making bad products, more difficult to deal with. So it has to adhere. It's very specific. It has to be firm. Okay. And so that's some of the difficulty. If you think it's where the term lavatory comes from, lavage. A lot of times we'll get an open wound like there, and the first thing we do is we start in the emergency room, you start taking big bulb syringes like giant turkey basters, flushing that bad boy out. Dissolve some betadine in water and flush it and flush it and flush it and flush it because you're trying to avoid it. And it's your body does the same thing to a certain extent, but the mechanical aspect prevents it, not precludes it, prevents it to a certain extent, limits it, the likelihood that it will appear. Precludes means doesn't allow it to happen. That would be incorrect. And you see those pili we talked about ages ago, proteins latching on, those slime layers, viruses. We looked a bit at the anatomy, and you'll see it. It's those protein spikes, and they're very, very specific. And worms, which I don't do, but there's all sorts of neat little attaching things that create the problem. So normally they would be phagocytized, cells that engulf and destroy enzymes, but they have factors. Okay. They may make these chemicals that actually kill phagocytes. That slime layer makes it difficult to swallow. A capsule. Talked about that endlessly, and you can see it in respiratory disease like tuberculosis, like pneumonia. And like tuberculosis, they can live inside a phagocyte. It's a minefield out there, everybody. And step 4, factors are simply adaptations a microbe uses to establish itself. So again, and this is the important part, direct means enzymes or toxins. Bacteria are all about exotoxins and against gram negatives or endotoxins. Indirectly is your immune system, altering basically inducing your host to typically overreact. And then even making changes to your host cells. That's a bit more advanced, but that would be like HIV. So when they call epigenetic means outside of the normal genetic mechanisms, literally implanting genetic material by intent. And that's what happens when we look more closely at HIV/AIDS. So viruses are much more about this, your immune system. Certain bacteria are. A strep throat is less about the damage it does to your throat because that always gets better. It's the damage is your immune system going into overdrive for no good reason and attacking structures it shouldn't, or producing extraordinary toxins that go throw your immune system into hyperdrive. We will address those as well. And so those are directly from the toxin, typically, or enzymes that are secreted that start gobbling up stuff versus indirectly through your host defenses. And they're just looking at exotoxins from bacteria, microbes with enzymes that and what they do is they start to attack the barrier. Interestingly, streptococcus makes an enzyme that attacks barriers like this. Here we are living inside of a phagocyte, altering the defenses itself. And so again, we have enzymes that they secrete called exoenzymes. Okay, exits the entity, such as it dissolves the barriers and promotes the spread. So a lot of what they might gobble up mucus. Mucus is a protector. Sticky, it traps stuff. Hyaluronidase, basically that dissolves or breaks down connective tissue. That's in streptococcus, by the way. Coagulase, the critical piece that makes Staph aureus so nasty. That's a major virulence agent. That's really the virulence factor of Staphylococcus aureus. We will see this when we look at skin disease. In the old days, we just call it coag positive. This enzyme would coagulate the blood or the plasma, so the troops couldn't get there to fight it. And even here, streptococcus again, making kinase, we use it to dissolve clots. We did. Now we make it differently. And so all of these different toxins are important. I will stop it here with toxins because I don't want to give them a short shift. And I'm running out of time a little bit here because I got something else to do. This is a quick 25 minutes, and I'll give you some more, starting with all those different kinds of toxins. Get out of here and say thank you.